Welcome to today's session on sickle cell vaso-occlusive crisis. In this video, we will explore the causes, symptoms, signs, investigations, treatment options, and referral criteria for managing this condition. We will also include some USMLE-style questions to test your knowledge. USMLE-style questions. Question 1. A 15-year-old boy with known sickle cell disease presents to the emergency department with severe pain in his lower back and both legs. He also has a fever of 38.5 degrees Celsius, 101.3 degrees Fahrenheit. His pain started suddenly, and he reports no recent trauma. What is the most likely diagnosis? Answer: sickle cell vaso-occlusive crisis. Explanation: the patient's known sickle cell disease and presentation with sudden, severe bone pain and fever are characteristic of a vaso-occlusive crisis, a common complication of sickle cell disease. Question 2. A 12-year-old girl with sickle cell disease presents with bone pain, fever, and tenderness over her left femur. Her blood work shows elevated ESR and CRP. Which investigation would be most helpful in differentiating between vaso-occlusive crisis and acute osteomyelitis? Answer: blood culture and sensitivity. Explanation: while vaso-occlusive crisis and osteomyelitis both present with bone pain and fever, blood cultures can help identify a bacterial infection indicative of osteomyelitis, allowing for targeted antibiotic therapy. Question 3. A 25-year-old woman with sickle cell disease presents to the clinic with a vaso-occlusive crisis. Her pain is not controlled with oral paracetamol. Which medication is the next appropriate step for pain management? Answer: morphine. Explanation: for severe pain unresponsive to non-opioid analgesics, opioids like morphine are appropriate and effective in managing pain during a vaso-occlusive crisis. Question 4. Which of the following is a non-pharmacological measure recommended for a patient with a sickle cell vaso-occlusive crisis? A. Cold compresses on painful areas. B. Rest and warm compresses on painful areas. C. Strict bed rest without compresses. D. Vigorous exercise to improve circulation. Answer: B. Rest and warm compresses on painful areas. Explanation: rest and warm compresses can provide comfort and help relieve pain by improving blood flow and reducing muscle spasms. Question 5. When should a patient with a sickle cell vaso-occlusive crisis be referred to a specialist? A. Only if there is evidence of severe infection. B. If pain persists despite standard analgesic treatment. C. After 1 day of conservative treatment. D. In cases of mild pain controlled with oral analgesics. Answer: B. If pain persists despite standard analgesic treatment. Explanation: patients whose pain is not managed with standard treatments or who develop complications require referral to a specialist for more intensive monitoring and management. Sickle cell vaso-occlusive crisis. Sickle cell vaso-occlusive crisis is a painful complication of sickle cell disease caused by the obstruction of small blood vessels by sickle-shaped red blood cells. This leads to ischemic injury to various organs, including bones. The pain associated with this condition can be similar to that seen in acute osteomyelitis, making differentiation important. Causes: pyogenic infection. Infections can trigger a crisis. Malaria. In regions where malaria is endemic, this can precipitate crises. Dehydration reduces blood volume and increases blood viscosity, promoting sickling. Severe anemia, lower oxygen carrying capacity, can lead to hypoxia and sickling. Stress and anxiety can act as a trigger for vaso-occlusion. Symptoms: bone pain, the hallmark symptom, often severe and sudden in onset. Fever, common due to infection or inflammation. Sickle cell anemia, patients will have symptoms related to chronic anemia. Signs: bone tenderness, commonly in the long bones, spine, or pelvis. Fever, indicates possible infection or inflammation. Investigations. Full blood count, FBC, erythrocyte sedimentation rate, ESR to assess anemia and inflammation. C-reactive protein, CRP elevated in inflammation and infection. Sickling test and hemoglobin electrophoresis, confirms sickle cell disease if not previously diagnosed. Blood film or rapid diagnostic test, RDT, for malaria parasites, essential in endemic areas. Urinalysis and culture, to rule out urinary infections. Blood urea and electrolytes, BU, and creatinine, to monitor renal function. Blood culture and sensitivity, important for diagnosing underlying infections. Treatment. Treatment objectives. Manage pain effectively, essential for patient comfort and well-being. Prevent and treat infection, crucial as infections can precipitate crises. Rehydrate, helps reduce blood viscosity and prevent further sickling. Supportive care, to manage complications and promote recovery. Non-pharmacological treatment. Ensure adequate hydration, encourage oral fluids or provide intravenous fluids. Rest the affected areas, to prevent further damage and pain. Warm compresses, applied to painful areas for comfort. Education, teach patients and caregivers to recognize early signs of a crisis for timely medical intervention. Pharmacological treatment. A treatment of underlying malaria. Use anti-malarial drugs such as artemisinin-based combination therapies, ACTs. Examples include artemether-lumefantrine and artesunate-amodiaquine, dosed according to age and weight. B. Treatment of other infections. Start with broad-spectrum antibiotics, e.g., ceftriaxone, amoxicillin clavulanic acid, while awaiting culture results. For confirmed osteomyelitis, use intravenous antibiotics like clindamycin or vancomycin. C. Rehydration. Administer isotonic fluids such as normal saline or Ringer's lactate intravenously to restore fluid balance. D. Analgesia. Non-opioid analgesics. Paracetamol. Adults, 500 mg to 1 g every 6 to 8 hours, max 4 g/day. Children, 15 mg/kg every 6 to 8 hours, max 60 mg/kg/day. Ibuprofen. Adults, 200 to 400 mg every 6 to 8 hours, max 2.4 g/day. Children, 10 mg/kg every 6 to 8 hours, max 40 mg/kg/day. Opioid analgesics, for severe pain. Morphine, 0.1 mg/kg subcutaneously or intravenously every 4 hours as needed. Pethidine, 1 mg/kg subcutaneously or intravenously every 4 hours as needed, avoid prolonged use. Referral criteria. Severe pain, not relieved by standard analgesic regimens. Complications, such as acute chest syndrome, stroke, or priapism. Severe infection or sepsis, requires intensive monitoring and management. Recurrent crises, that are difficult to manage or require specialized care. Sickle cell Vaso Occlusive crisis. This is a painful complication of sickle cell disease, caused by the obstruction of small blood vessels by crystallized sickle cells, leading to ischemic injury to various organs, including bones. The bone pain in this condition can be challenging to distinguish from acute osteomyelitis. Causes: pyogenic infection, malaria, dehydration, severe anemia, stress and anxiety. Symptoms: bone pain, fever, sickle cell anemia. Signs: bone tenderness, fever. Investigations: full blood count, FBC, erythrocyte sedimentation rate, ESR. C-reactive protein, CRP. Sickling test and hemoglobin electrophoresis, if not previously known. Blood film or rapid diagnostic test, RDT, for malaria parasites. Urinalysis and culture. blood urea and electrolytes, BU, and creatinine. Blood culture and sensitivity. Treatment. Treatment objectives. Manage pain effectively. Prevent and treat infection. Rehydrate the patient to reduce blood viscosity. Provide supportive care to manage complications. Non-pharmacological treatment. Ensure adequate hydration by encouraging oral fluid intake or providing intravenous fluids if necessary. Rest the affected areas to prevent further pain and damage. Use warm compresses on painful areas to provide comfort. Educate the patient and caregivers about recognizing early signs of a crisis to seek prompt medical care. Pharmacological treatment. A. Treatment of underlying malaria. If malaria is suspected or confirmed, treat with appropriate anti-malarial drugs such as artemisinin-based combination therapies, ACTs. Common choices include artemether-lumefantrine, artesunate-amodiaquine, or dihydroartemisinin piperacquine. Follow local guidelines for dosing and duration based on the patient's age and weight. B. Treatment of other infections. Use broad-spectrum antibiotics initially while awaiting culture results, especially if the infection source is not immediately apparent. Common choices include ceftriaxone or amoxicillin clavulanic acid. Adjust based on sensitivity results. If there is evidence of osteomyelitis, treat with intravenous antibiotics such as clindamycin or vancomycin, as indicated by culture and sensitivity tests. C. Rehydration. Administer isotonic fluids like normal saline or Ringer's lactate intravenously to restore fluid balance. Aim for 1.5 times the maintenance rate to ensure adequate hydration and reduce blood viscosity. D. Analgesia. Start with non-opioid analgesics such as paracetamol or ibuprofen for mild to moderate pain. Paracetamol dosage. Adults, 500 mg to 1 g every 6 to 8 hours, not exceeding 4 g per day. Children, 15 mg/kg every 6 to 8 hours, not exceeding 60 mg/kg per day. Ibuprofen dosage. Adults, 200 to 400 mg every 6 to 8 hours as needed, not exceeding 2.4 g per day. Children, 10 mg/kg every 6 to 8 hours, not exceeding 40 mg/kg per day. For severe pain, use opioid analgesics. Morphine, 0.1 mg/kg subcutaneously or intravenously every 4 hours as needed. Pethidine, 1 mg/kg subcutaneously or intravenously every 4 hours as needed, but avoid prolonged use due to the risk of dependency and accumulation in renal impairment. Referral criteria. Refer patients with severe pain not relieved by standard analgesic regimens. Refer patients with suspected or confirmed complications such as acute chest syndrome, stroke, or priapism. Refer all patients with evidence of severe infection or sepsis for intensive monitoring and management by a pediatrician, physician specialist, or hematologist. Refer patients with recurrent vaso-occlusive crises that are difficult to manage or if there is a need for specialized care. This comprehensive overview of sickle cell vaso-occlusive crisis includes its causes, symptoms, diagnostic methods, treatment options, and referral criteria. Early detection and prompt management are crucial for improving outcomes in patients with sickle cell disease. Stay informed, and always seek prompt medical care when symptoms arise.